which I know a lot of us are dealing with now across the world. So thank you for joining us during our during your lunch hour or wherever you are across the world. Thank you for joining us. We are discussing this. It is January 14th, Friday. However, if you're listening to this after the fact through Facebook or YouTube or whatnot, then know that some things can change over time with COVID, and so please check the news, do your own research. Things do change with COVID, so we're going to navigate these waters together, and we're just going to get started, I think, here. So we'll talk today about topics. So some of our topics for today are the Omicron variant and the biology of this particular variant of coronavirus. Also some clinical considerations, what we would do for things like prevention and treatment, some guidelines around masking, social distancing, and testing, quarantining, things like that. And then some of the research updates, which are pretty exciting that are coming out here. Besides that, we're going to also talk about vaccines and boosters and protocols to boost your own immunity and those around you that are your loved ones. And then some of the future directions that we're kind of thinking here in terms of holistically about what's next for COVID and the pandemic and how we can all move through this healthily together. Just a little shout out to our recent guests on the podcast that we've had. We have a podcast now that we started in September. So Jen's been doing an amazing job on this. Recently, we've had Danny Williamson on to talk about healing trauma and 6 practical steps to wellness. Dr. Gilman talked about burnout and stress during the pandemic. Dr. Thompson talked about chiropractic care for pain and many other facets of chiropractic care. And then Dr. Anderson talked about IV nutrition therapy for fatigue, infections, cancer, and much more. So please check that out if you haven't already. It's available through Spotify, Apple, and YouTube. And I think those are the main platforms. So let's just take a few minutes to put our hands on our heart and send in gratitude to our own immune systems. We're producing about 100 billion white cells per day, keeping us healthy, keeping our loved ones healthy. Just taking a couple of deep breaths, putting your hand on your heart, just feeling the blood rush through your body, the white cells protecting you through this time. Just take a deep breath in and out. Just giving thanks to your body for always being there for you, defending you, protecting you, and just being there in every moment for you. Just taking this pause right now to do that. One more breath in and out. Thank you. So we have a few slides on official resources for COVID. Here you see the resources here for the CDC, World Health Organization, and the DMV area. Here's kind of where we are right now in terms of worldwide, how many deaths there are daily, still quite a lot. Also in the US and then locally, there's still quite a lot of cases and deaths. I think this is still to be determined, but Dr. Walensky, who's the director of the CDC, stated a couple of days ago that right now most of the fatalities are lagging deaths from the Delta variant wave, and we'll talk about Delta versus Omicron in a minute. So coronaviruses in humans, just as a review from last time we did this webinar, there's 7 known coronaviruses that can infect people. There's over 100 coronaviruses that infect different animals. Coronaviruses there's 3 big things about them that make them more susceptible to genetic changes, i.e. mutations, as viral replication occurs. Number 1 is that they're single-stranded versus double-stranded. They have a ribonucleic acid versus deoxynucleic acid, or RNA versus DNA. And then they have a relatively small genome size, meaning that the amount of genes that they have is about 30 kilobases versus a larger genome size. So all those 3 factors make them more susceptible to genetic changes. And so this is why we see in coronavirus, COVID pandemic here, that coronavirus is constantly changing and mutating because of these anatomic factors. All coronaviruses do cause mild symptoms. We think about common cold symptoms that we'll go over a little bit later, but they can also cause bronchitis, pneumonia, and even respiratory failure and potentially systemic dysfunction to other organs as well. 229E and then some of these other ones here are the ones that have been endemic for a while in the human population. These four here typically cause common cold symptoms. Then you have two called MERS and SARS-1, and then SARS-2, which was detected in, I think, November 2019. That was novel to the human system as of 2019, and we've seen yearly different mutations arise spontaneously from different strains of this. So when we talk about variants and what that means, variants just means it's a different virus because it's a collection of mutations, a collection of genetic changes that occur in the same virus. So that's why it's called a variant. So we've had the original strain, we've had Alpha, we've had Delta, many others, and now we've had Omicron, which is also classified as B11529. There's going to be others that are presently being tracked, I think, by the health authorities. And also there'll be variants in the future as well. By changing viral structure, mutations change viral function, and this change in function then interacts with the host, that's us as humans, in different ways. So here's the spike structure of SARS-CoV-2, meaning coronavirus, the coronavirus that causes COVID-19. So the spike protein on the virus, you see that like club-like purple projection sitting out there, and it attaches to the ACE2 receptor on human cells. So this is an anatomic model of that, but that's kind of what happens when infection happens. Now, talking about different viral variants, Delta and Omicron are both coronaviruses and both coronavirus SARS-CoV-2 variants. But with the different mutations, and because Omicron didn't arise genetically from Delta, they're really very different viruses. Delta started around, we think around October 2020. Omicron started potentially around November of last year. So there are three big mutation categories that make Omicron different from Delta and make it behave different. Remember that change in structure equals change in function. So some of the mutations, and I should just review and say that there's three main parts of the spike protein. One is called the RBD, or receptor binding domain, and that basically helps this virus bind to human cells. There's also something called the N-terminal domain, which I think researchers don't know exactly what that does, but from a perspective of our immune systems, the antibodies often search for that NTD or N-terminal domain to recognize the virus and try to kill that off. So we have a receptor binding domain and we have an N-terminal domain. And then there's something called the furin cleavage site. If you're interested in that, you can look that up. It's FURIN cleavage site, and that helps viruses enter into cells and replicate. So those are the three major parts of the spike protein. There are different mutations in different subparts of the spike protein, and you can see here that many of the mutations in Omicron in the receptor binding domain make viral binding to the cell stronger, and that's why Omicron is more transmissible. There are also some mutations in Omicron's N-terminal domain, and that may make antibody binding, meaning human antibody binding to the virus, less efficient. So it evades the immune system, and therefore Omicron is more infectious. And then the other thing that's really big about Omicron versus other variants, all other variants pretty much, is that Omicron's method of cell entry differs from previous major variants. So Ravindra Gupta, who's a variant researcher and expert at Cambridge University that authored a study on Omicron versus Delta, said that Omicron is really doing its own thing in many ways, even though it's the one that came after Delta. So whereas the original virus, SARS-CoV-2, the Alpha variant, and Delta variants all use cell fusion, which is dependent on a molecule called TMPRSS2. This cell fusion, again, if it's dependent on TMPRSS2, this molecule is highly concentrated in the lungs. Now, TMPRSS2, however, is not very concentrated in the bronchial tubes, meaning the upper airways. It's really not found very much in the nose and mouth. So Omicron is using a different way to enter the cell called endosomal fusion. So it basically tends to infect cells that don't have as much TMP or SS2. So it's going to infect the nose and the mouth and the upper airways much more, which does make it overall less virulent, that we're going to see in some studies in a little bit. Now, interestingly, we should talk about exposure versus infection. So not everyone exposed gets infected. Many public health authorities have said that we're all going to get exposed, if we already haven't. Not everyone exposed gets infected, and this could be because of different aspects that we can talk about later, including the role of previous T cells that would confer some natural immunity or some kind of force field shield to us. But there are some people that don't get infected even though they're exposed. So with Delta, pretty much everyone had symptoms if they got Delta. 97% of people infected with Delta had or have symptoms. However, with Omicron, the study's shown, and there's two studies that have been done on this, but they have shown that 69 to 84% of people, depending on the study, with Omicron have symptoms, which means that about 15 to 30% of people with Omicron that have an infection do not have symptoms. And just in general, when we talk about viruses, we can look at what the rate of infection is, how easy it is to infect, others. For instance, we can look at the severity of infection, things like, does infection result in symptoms? Does it result in hospitalizations or deaths? And then we can look at duration of infection, which basically means how long it lasts for, both, in terms of the acute setting, but then the kind of post setting, how long it might last for after that. So all of these aspects of basically how severe or how affecting this is in your lives and all of our lives here about, Omicron is going to be dependent on two factors. Number one is the virus itself, but then number two is the host, which is us. So we have the virus, and the question of viruses is basically how infective is it? How transmissible is it? How virulent is it? And we saw in the previous slides that these mutations are making Omicron in general, and this is a general statement now, but it's going to make it more infective, more transmissible, but slightly less virulent at least. At the same time as the virus, there's also something in what we do here at CIH, of course, in integrative health, functional integrative naturopathic medicine. We often talk about the terrain. So the terrain is how healthy we are as hosts, right? As potential hosts that have an immune system. So we have to talk about host immune system strength, meaning how strong the B cells, the T cells, the natural killer cells are, how easy is it for us to mobilize that quote unquote army of 100 billion white cells a day. And then we have to talk about immune system balance, which is basically as we mobilize and we kind of battle these microbes, let's say, or kind of keep our systems protected and defend ourselves, we don't want to tip over to too much inflammation or too much like attacking our own system. And so that's where we talk about strength and balance there. So again, rate, severity, and duration of infection, as well as potential post-infectious sequelae, things like long COVID, et cetera, are dependent on both viral factors, but also host factors as well. So just as a review, there's different lines of the immune system. You can think of this as different like front lines, back lines. We have mucous membranes. We have antibodies like secretory IgA, natural killer cells, different types of white cells, including mast cells, macrophages, and then B cells that kind of pump out kind of like bullets from a gun, neutralizing antibodies that can go and try to hunt for these different viruses or other infections. Now, if viruses or other infections get past the first line, you have the second line. So let's say if COVID-19, or I should say on here, coronavirus variants get past neutralizing antibodies in the upper respiratory tract and then get inside the cells, then that often changes the expression of the cells, and then the T cells activate. And then T cells are some of the backline cells. So we can see that in different studies, including one that is cited here, that people that were not exposed to coronavirus still had some reactivity, meaning preparation, I guess, from the T cells because they've been exposed to common cold coronaviruses before. So this is a theory, but the idea is that people that are not getting as sick from it or even getting symptomatic from either Delta or Omicron, maybe they had some T cell preparation from other sort of quote unquote cross-reactive common cold coronaviruses that look somewhat similar to the COVID-19 coronavirus. So in a way, it's kind of a race against time. It's sort of this viral replication versus T cell replication versus B cell replication, and this can often predict what the severity, if someone is going to get symptomatic, and then if they are, how symptomatic they're going to be. So again, B cells, we can kind of consider that for our purposes today, that part of the front line of the immune system producing these neutralizing antibodies, kind of shooting out of them, protecting us. But as you saw in the previous slides, mutations in the N-terminal domain of the spike protein in the Omicron coronavirus variant may lead to immune system evasion of these frontline antibodies. So the T cells are the backline. They're kind of the sitting in the back in case they're needed, and they serve in part as a memory system if and when reinfections occur. And so therefore, if someone has a coronavirus in the past of some sort, and then they get exposed again, this may lead to increased responsiveness of the immune system of the host to the same or a similar virus. Now, it's interesting that if T cells are in the nose or the mouth and they're circulating there and they can get to the virus quick enough, then it's possible that that backline becomes the front line. So that's why I put there, could T cells be a front line? They could be in some situations. And then I think the other thing here is we talk about antibodies a lot and checking antibodies, and is someone immune to a virus and things like that. But there's not a real good way to check on the labs for T cell responses. So, but we know that because the T cell response is more inclusive of various parts of the virus, Omicron has been shown to be recognized and neutralized by the T cells more effectively than the B cell antibodies that are produced by the B cells. So here's some studies that are pretty recent now, and we're going to be talking about essentially reduced effectiveness of neutralizing antibodies that are stimulated by vaccination seen versus Omicron. So the neutralizing antibodies were a bit better against Delta, but now in the Omicron era right now, we have Johnson & Johnson. It's not recommended by CDC as first line anymore for various reasons, including a rare risk of some blood clots, I believe, in some people, but also because it doesn't really work against Omicron. Novavax and Sinovax, which are used around the world, also unfortunately are not effective. And Pfizer and Moderna, the 2 series, only dropped to 10 to 30% effective, which again is not that effective against symptomatic infection. However, a UK study from December of last year now showed that a third dose of Pfizer or Moderna did boost it up to about 75% effective against severe disease and hospitalization. So that third shot seems to make a difference. We're going to talk more about boosters in a minute. Besides neutralizing antibodies, there's also just injecting antibodies. So that's the monoclonal antibodies that we've all heard about. So unfortunately, there's also reduced effectiveness of most monoclonal antibodies given by injection seen versus Omicron versus the other variants that were seen before. So preclinical studies show a partially reduced effectiveness of the VIR 7831, which is sotrovimab. So that's the one that still has some effectiveness, but it's still, even that still got reduced versus Omicron. There was drastically reduced effectiveness, and these are no longer recommended against Omicron anyway. They would still, I think, help for Delta of these other monoclonal antibodies called Regeneron and Evusheld. My understanding is that, for reference, at least in the US, we're probably about 95% dominant for Omicron right now. So it is mostly Omicron. Okay, so let's talk about how T cells work and T cell effectiveness against Omicron. So lab studies, this is really interesting. Lab studies show that T cells that are taken from people who have either received a COVID-19 vaccine or been infected with a previous variant of COVID-19 can respond to Omicron. And this is likely because the sites in the SARS-CoV-2 genome that T cells target are present in Omicron. So basically, there's the spike protein that's on the coronavirus, but then there's all these other proteins that coronavirus also makes, and is part of that virus. So even though the mutations in the spike are likely kind of messing up the T cell response to the spike, the T cell responses targeted to the non-spike part of the genome remain intact because there's not that many mutations in the non-spike part, thankfully. So this is a big study, and I encourage you to all read this. There's a link down here. It's a preprint study on medrxiv.org. This is a study that was just released. 70,000 patients at Kaiser Permanente, Southern California. These are outpatients. 70,000 people, about 52,000 with Omicron and about 17,000 with Delta. And they tested positive for either Delta or Omicron. So they did an analysis of 70,000 people. And this was done when Delta and Omicron were both pretty prevalent. So for all people testing positive for Delta, they found that 49% of the people that tested positive for Delta were not vaccinated. 38% of people received 2 doses of an mRNA vaccine, and then 4% received the vaccine plus the booster. And there's some other statistics, but these are the ones that were the most prevalent, so that's why I highlighted them. For all patients testing positive for Omicron, which is a little bit later down the line, 26% of the people that tested positive for Omicron were unvaccinated. 52% received 2 doses of the mRNA vaccine, and then 13% received the vaccine plus booster. And the authors' conclusions were that unvaccinated SARS-CoV-2 naive patients, meaning they didn't get a vaccine or they have not had an infection before, were at the greatest risk of hospitalization from Delta or Omicron. However, they also noted that the risk of symptomatic hospitalization, if someone got an infection naturally greater than 90 days prior to that positive test, that did markedly reduce the symptomatic hospitalization case rate. In addition to that, there was evidence for lower vaccine protection against infection by Omicron versus Delta, which we all have seen, I think. But there was still a reduction in severe outcomes in vaccinated individuals after both infections. So vaccines are still protective to some degree here. I thought this was so interesting here because the overall sheer numbers of people hospitalized were fairly low. I mean, obviously, no one wants to get hospitalized, for coronavirus. But with Delta, it was 1.3% of patients that were of all comers in this large Kaiser system were hospitalized with Delta. And for Omicron, it was cut in more than half. It was 0.5% of patients with Omicron were hospitalized. Now, I looked at the paper, I read the paper, and it did seem like these were real cases that weren't just like randomly going into the hospital and then diagnosed after the fact with COVID, because at least they said that greater than 95% of these cases were symptomatic with acute symptoms within 14 days of admission to the hospital. So there were some people that were hospitalized. However, they did notice a short hospital stay, meaning 2 days or less, and 83% of Omicron versus 31% of Delta. And I think this is a really important point to know, and hopefully this also bears out with other parts of the country. But in this study, among patients with Omicron, there was only 1 death. There was 0 people on ventilators. 1 person did end up dying. Among patients with Delta, there were 11 people on ventilator, and overall there were 14 deaths attributed to Delta in this study. So although Omicron has been shown in various studies to overall be less virulent on a population-wide level, it is a double-edged sword because certain subgroups are still at potentially increased risk based on exacerbation of existing conditions. People that have moderate to severe immunosuppression, people with chronic lung or heart disease, people with diabetes, people with obesity would still be at greater risk. The steepness of the Omicron wave is also resulting in a lot of overwhelm for the nation's healthcare system, especially inpatient with hospitals, et cetera, with caregivers, both, like family members, the school systems, the workforce. So there's a possible detrimental effect on the system of the steepness of the wave and the number of cases that is happening right now on accessing medical care for other serious conditions, even if it's not related to COVID-19. There's also a disruption of social services and social fabric that you see with, bus drivers and teachers and, just community members overall getting sick, having to call out of work, not being able to volunteer and all this stuff. So the peak is now happening in many areas of the US. I believe in DC, they're kind of estimating that it already peaked, but it's certainly around the time, plus or minus 1 week of this. Thought this was really good, a nice article kind of just summarizing the general symptom comparison between Omicron versus Delta versus influenza virus versus other common cold viruses. I think just to point out, you see that they all have cough, they all have runny nose. I think Omicron is more like a common cold with sneezing. Sore throat is a very common symptom as well. You can see that Delta is the only one on this list that is more commonly seeing a shortness of breath, and that's because the virus tends to invade the lung more with Delta because of that TMP SS2 molecule that we talked about earlier versus the others. Fever, you can see that in any of them. Night sweats, and I couldn't figure out why in terms of mechanism. I don't know if people know that yet, but it seems like that's more significant for Omicron versus the others. Sometimes you can get chills, you can get headache, that's very common. Loss of smell is possible. We have seen that in our clinic, but definitely more with Delta and the previous variants. And then fatigue is also very common. Oops, sorry. Let me just go back. Now, how long symptoms take to show up, you can see that it's shorter for Omicron than with Delta there, about 2 to 3 days. So let's go into vaccines now. We can talk about how vaccines work, what they do and what they don't do. So vaccines are going to stimulate the immune system. It's going to ideally prep the immune system to be more prepared if a virus hits. And vaccines will not prevent exposure to Omicron. That's just not what they do in general, any vaccine, not just COVID-19 vaccines. And anyone with an Omicron infection can spread the virus to others regardless of vaccination status. This may depend on viral load. It may depend on things like hand washing and masking and social distancing and things like that. But overall, we see that it is highly spreadable. It's very exposed, I think, in society right now. However, current vaccines are effective at preventing against severe illness, hospitalizations, and death. And I think we still see that with Omicron. Just to kind of review the CDC guidelines, CDC does recommend full vaccination for everyone age 5 and up now. And then the question of infection and like if someone's infected, I think someone had a question before this presentation, how long to wait before getting a vaccine or booster. Based on general vaccine principles, the option would be to wait 90 days after infection before getting a vaccine or booster. And if someone had a monoclonal antibody treatment, same thing, you have to wait about 90 days. So here's kind of some of the guidelines again. With Pfizer, it's age 12 and up, Moderna is 18 and up, that are eligible for a booster about 5 months after completing the primary series. They reduced the CDC went from 6 months, now it's 5 months after the first series. Sorry, I know there's a lot of questions. We're going to get to that in a minute. Jen, just let me know when you want to break for questions here. Age 18 and up for the J&J shot are eligible for an mRNA booster, not for a J&J booster. And they're not recommending that now because, like I said, it doesn't work against Omicron really. But they're saying you can do that 2 months after the initial J&J shot if you did get that shot. And then moderately to severely immunocompromised people got their third shot often in October or November of 2021. This is about 2.7% of the population. They're eligible for a fourth shot beginning this month. So it's important to know that the boosters are currently the original formulation. They are not. They have not changed since the variant's emergence. So they're the same shots that have been given before. Pfizer is planning to develop an Omicron-specific booster by this March, but I think a lot of people, including I think just common sense, if we're all getting Omicron right now, is it going to be helpful or not by then? I think that's a question. It's no one knows the answer to that, but that's a question that a lot of public health officials are asking: is it going to be useful and applicable by then? All right, so we can talk about testing, and maybe want to get through these intro talks. We can go into questions, but there's two main types of COVID-19 tests that we'll talk about today. We're going to be talking about NAATs, so nucleic acid amplification testing. That's the test that is commonly known as reverse transcriptase PCR, or polymerase chain reaction. That's a PCR test. Usually takes a couple of days to come back mostly. This is a very common methodology and is considered the gold standard for detecting COVID-19 RNA. So it's going to identify your RNA sequences that comprise the viral genetic material. It's highly sensitive, about 80 to 90%, but it might pick up dead viral material or it might miss the virus depending on the swab source. So we know that with Delta, for instance, it was more of the nasopharyngeal area that gets infected. With Omicron, I think it's like 50-50, where sometimes it affects the nose, sometimes it affects the mouth. So the NIATs are typically built, if you look at a lot of the ones that are out there, the instructions say to swab the nose. And I think a lot of people are talking online about how should you swab the mouth or not? It's officially not recommended, but that's something to think about anyway, because if you're having a sore throat and you swab your nose, you may not pick it up as much as if you were swabbing your mouth. But officially, you want to go by the directions. It's 98 to 99% specific. So what that means is if you have a negative test, it's pretty specific that person is unlikely to have the disease. And then besides the PCR test, there's also what are called rapid tests, rapid antigen tests. So they'll check for things like the spike protein, they'll check for the nucleic acid, et cetera. But antigen tests are not as sensitive. They're actually only 65% overall sensitive in picking up infection and only 44% in asymptomatic individuals. So when you think about it that way, if up to 30% of people with Omicron are asymptomatic, this test only have a 44% sensitivity to detect. However, there's a 98 to 99% specificity. So if negative, the person is unlikely to have disease if it's negative still. So it could be a little confusing with statistics there, but PCR is better, but the rapid tests are obviously more easily available and you can take them at home and things like that. And all pretty much the guidelines from the CDC are using rapid test as the general recommendation because they're more available and everything. So we'll talk about that. So quarantine. So let's say someone gets COVID. Let's talk about transmission. So first of all, according to data reviews, the majority of transmission of virus happens in the first 1 to 2 days before showing symptoms, and then in the 2 to 3 days after showing symptoms. So that's about a 5-day window there. What is typically recommended now is if someone tests positive, the CDC, as you probably know, did decrease the quarantine time from 10 to 5 days. The reason for that was probably a variety of factors, but one of the factors is that more people are infectious. Often, the majority of the infectivity is in that first week. So that's probably why. It doesn't mean that people can't be infectious, after that, but that the majority is in that first week. So it's recommended to isolate at home for at least 5 days, with day 0 counting as when the symptoms. You're counting day 0 as when the symptoms started. Now, the CDC doesn't say this part, but we would say, in general, consider testing at day 5 with a rapid antigen test. The PCR, or what's called the NAAT test, nucleic acid amplification testing, can be positive for up to 3 months after initial positive test. And so that's not helpful, basically, because it doesn't mean they have infection. It might just mean you have dead virus in there, dead viral RNA particles. So if that person has a negative rapid antigen test, then you can break quarantine. If it's positive, you could probably quarantine for a total of 10 days instead. And none of this applies if someone still has symptoms, right? If they're still coughing, if someone's coughing, having runny nose, et cetera, short of breath, then see your doctor about that and see your practitioner, and you may still have to quarantine. So masking guidelines. So here is the kind of the thought about masks right now is that cloth masks can prevent exhalation of particles, but not really inhalation of particles. And the thought is that with Omicron and just more transmissible and a higher viral load, cloth masks are not as recommended now as a more well-fitted, better quality mask, such as a triple layer surgical mask or N95 mask. If you wear these masks, you do want to keep them dry to prevent degradation of polypropylene, which can also release microplastics into the environment. So that's important to know. I also am just curious if anyone wants to write in the chat that knows of other masks that are ecologically friendly. I'd love to hear about that because we're trying to research that too. We do recommend that you also get outside and get fresh air periodically if you're wearing masks for part or some of the day, so you can detox your system, get some fresh air in your lungs, and kind of exchange that oxygen, carbon dioxide when feasible. So we had questions about kids, and I know that a lot of you have kids or know kids, and we know that kids are now kind of being hit with coronavirus a lot. They're going back to school, a lot of times. So up to 1/2 of kids, based on studies with COVID-19 infection, are asymptomatic, and I think that goes back to that whole coronavirus cross-reactivity thing, where 40 to 50% of people might have had a coronavirus in the past. This is more likely to be kids because they're running around and playing with their friends or in people's faces, their friends' faces and stuff throughout their lives. So they're getting these T-cell responses. That's my theory about why more kids are asymptomatic versus adults. The Pfizer vaccine is approved for kids 5 through 15 through an emergency use authorization. Um, for ages 16 through 17, it does now already have FDA full approval for a while, so that's happening. In addition to that, the general things about side effects as well as COVID severe cases, um, it's similar to adults, I think, in terms of a lot of it's similar to adults, I would say. They're the same health factors that would increase the risk of severe illness for kids are similar to the health factors that would increase the risk of severe illness in adults. Let me see. Jen, should we look at questions?
Yeah, maybe take a few minutes and then we can
Take a couple minutes as we get into the immune part of this. Thank you for all the questions. Also, thank you for all of our team here that put together some of the questions, all the community members that asked some questions on Facebook and things. So thank you for all of that. Let's see. Yeah, so having the common cold might protect against Omicron. I think that the other thing to remember is that the common cold is caused by different viruses, right? You can have parainfluenza, you can have RSV, you can have coronavirus, you can have what else is there? Adenoviruses, rhinoviruses, and things. So I think the estimation is about 15 to 20% of all common colds are coronaviruses. So if you happen to pick up a bunch of colds, over the years, it's likely that one of them is coronavirus, but there's not really a way to tell that. There are people that, you would want to hold off on vaccination due to immune system issues. Yeah, if you want to be more specific about that, we can talk about that. There's no research yet on Omicron and long COVID, because it just happened, and the definition of long COVID, we're going to talk about that in a minute. That's a good question. So the answer is we don't know about Omicron and long COVID yet. That's a great question. If your B cells and T regulatory cells don't work well, or if you don't have as many, does that mean the vaccines won't help? It probably will help still. Remember that when you have any stimulus like a vaccine or an infection, that stimulus is going onto a host, which is us, right? So the health of the host is going to determine in large part both our response to infections and also how effective vaccines are, how well they work. So I think that would make a difference, yes. How strong are your T cells from past cold infections to determine your terrain? I don't know that there's a way to know from past cold infections. Yeah, I mean, there's different other tests, like we can do natural killer cell counts, which is a different type of immune cell, and things like that. There probably are some T cell activity tests out there too. Yeah. If a cough persists and ear ringing continues with Omicron, are they mild symptoms? Probably not, because the duration we're talking about typically for most people 3 to 4 to 5 days, a week. If it's after a week, I would consider that not long COVID, but I would definitely consider that longer than most people on average. So yes, it can cause bronchitis. And then the other thing to remember is you do want to talk to your practitioner if needed about, if someone's having a fever and chills and it's been, especially as it gets to that 2 week mark, you start thinking about secondary bacterial infection. So you should see someone about that. So yes, it can cause bronchitis. Yeah, so yeah, definitely see someone about that. Definitely need to get that addressed. Thank you. The PCR testing, yes, it cannot determine which variant one would have. I think that's done on a state level. Does anyone know that? Basically public health level. It's not usually done on like an urgent care or an outpatient level or an ER level, I think. It might be an ER, I'm not sure. Maybe someone can tell us that. But generally it's not available in an easy to access way, let's put it that way. Tinnitus is worse after testing positive. I think we think about inflammation, we think about inflammation of some of those nerves, like the vestibular nerve or the cochlear nerve, or, different cranial nerves that might be inflamed. Viruses inflame nerves, we do know that. So there's ways to reduce inflammation, to build up the to kind of support the nerves, that I guess we could talk about more. But that's probably why is the answer. Does an infection with Omicron provide any protection from a subsequent Omicron infection. I don't think that's totally known yet. I think the general thought is that it might to some degree. Remember, if the T cells are in the front line, if they kind of move from back to front, kind of like a football game, you'll have your, sorry to use a football analogy, but you have the safety kind of move up and go in the front line. That's kind of like what's happening. If infection can be prevented. Coronaviruses, they're single stranded, they're RNA, they're short genome, they're going to mutate. And also, our systems are not built like naturally, our systems are not generally created to have long lasting antibodies against coronavirus because our systems are meant, well, I wouldn't say they're meant to have colds, but we're exposed to cold viruses, multiple times a year. So the likelihood is that there's some protection, but it's not full protection because we generally speaking, except for these quarantine times, we typically have been exposed to different cold viruses, multiple cold viruses, even every single year. Sometimes some people get symptoms and some don't. It might just be based on your immune system, but most of us are exposed multiple times a year to different viruses. So I think our systems are built to have the T cells being lasting, but not the B cells quite as much. And you see that in studies that after 5 or 6 months, those B cells, those antibody levels are going to drop down a bit. And that's probably from the way we've kind of been created or evolved. So, okay. So I experienced an increase in ear ringing and tinnitus after getting the booster or mRNA vaccine. Are there studies starting to show that this can happen after receiving COVID vaccines and eventually goes away? I don't think there've been that many studies. Please, people that know about this, let us know here. Are there studies on? There are probably people that are researching this, or there are actually published studies on say vaccine side effects of tinnitus and things like that. The mechanism is going to typically be a variety of mechanisms. One could be an increase in interleukin-6, which we'll talk about in a minute, but basically causing inflammation of your nerves, just like with what Deborah was saying. If you have a booster and have been infected with Omicron, if you had a booster before Omicron, in theory, you should have higher protection. Yes. What about side effects from vaccines, including myocarditis and pericarditis? Yes. I mean, they're not considered common side effects, but they have been seen, and they're not like, I mean, they definitely are seen. I'll just put it that way. The quantity of that, I think it sort of depends. I mean, people get myocarditis from getting infection as well. So I think both are possible. So yes, that is a possible side effect of vaccines for sure. What is the criteria for monoclonal antibodies? There's a good website. Maybe Jen, you can find it on the Maryland site for monoclonal antibody distribution. You want to get monoclonal antibodies within 10 days. I know there is a issue with availability right now. And like I said, 2 out of 3 of the antibodies are more Omicron's kind of resistant to them. But yeah, you could also, we could talk about that more privately too. So yeah, I think again reducing inflammation, but yeah, that I think anyone that wants them that symptoms are still happening, if you can get an appointment in theory, that could be a criteria. Say it again about the 4th shot. It would be for immunocompromised individuals. So these are people with active cancer. They're getting actively treated with chemo. They're on biologics. They're on long-term steroids. They may have uh, other conditions like that, chronic lung and heart disease and things like that. If you had 1 dose of J&J and the Pfizer booster, might you be able to get the new second booster? Good question. I'm not sure the answer to that. There's no guidelines on that yet. You mean like if a new booster came out, like a variant specific booster? That's a good question. We'll have to see. Um, yeah, so definitely some people with Omicron have stomach issues. That's because we know that coronavirus does actually sequester in different organs. So it can, let's put it that way. So it can go to your gut, it can go to the brain, it can go to the kidneys. I mean, all these different things. So that's pretty common, diarrhea, nausea, vomiting. What is the protectiveness of one mRNA shot after Johnson & Johnson shot? Why are people who got the J&J advised to get only one mRNA booster? I would ask the public health officials that. I'm not really sure. I don't think they've done head-to-head on 2 boosters versus 1 booster. It may be for different reasons, and I guess I'm not really sure why, but I think my general educated guess is that they felt like maybe there was some protection against, Delta, but now with Omicron, things have changed. So they might revise it down the line. If you've gotten one shot, these are for kids and contracted COVID before getting the second, should you wait 90 days before getting the second dose? Yeah, I think so. Yeah. Because of the vaccine principles. Okay. Yeah, 90 days. Yep, 90 days to wait. Yeah, I mean, the CDC, when you go to their pages, and we're grateful for the CDC that they've been trying to figure out all this in real time, and it's probably difficult. I think some pages that I've seen on the CDC are contradictory to each other, though. So I do see that on the CDC. Is that I think there's some site that says get it immediately and then wait 90 days. So you should, I think, wait 90 days. It makes more sense because if you got infected, you're going to have some immune system response to that. So I don't see a point of getting a booster before 90 days. Treatment. Okay, we're going to get to that. I guess I will stop here and do some things and then come back at the 12:36 mark here. Okay, so we want to talk about how to build up your own immune system. This virus, for better or worse, is not going away. It's likely to become endemic, and we'll talk about that at the end too. But we want to talk about lifestyle factors. So we talked last time about sleep and nutrition, movement, mindset, relationships, connection, getting outside, getting light, getting nature, getting outdoors. Want to focus on one of the biggest, evidence bases for a more natural way to build up the immune system, which is vitamin D, specifically vitamin D3 and not vitamin D2. Okay, so vitamin D3 is actually a hormone that regulates gene expression. Specifically, what it does is it turns off inflammatory genes, among many other things. So, oops, that was not what I was trying to do. Vitamin D promotes synthesis of different peptides that are antimicrobial, including cathelicidin, LL37, and defensins. And basically, these compounds are broad spectrum antimicrobial compounds that are in your mouth, that are in your nose, that are directed against a variety of microbes, including bacteria, including viruses, including coronavirus, and yeast and fungi and stuff. So vitamin D helps. You need vitamin D to promote synthesis of these peptides. If you don't have a high level of vitamin D, you're going to have a low level of AMPs, or antimicrobial peptides. If you have a low level of antimicrobial peptides, you're going to be more likely to have upper respiratory tract infections. And the data bears that out, which I'll show you in just a minute. Vitamin D reduces the cytokine storm, which means it decreases inflammation. It decreases mortality in ICU patients with COVID. This is a study from Spain, from the Andalusian region of Spain. And then in a meta-analysis, which is a recent meta-analysis here by Borsch, there was an inverse risk of mortality with rising vitamin D status, vitamin D3 status. So they postulated that could raising serum vitamin D levels, 25 hydroxy vitamin D3 levels above 50 nanograms per ml, which is a pretty high level compared to kind of conventional ranges. But could that mitigate the impact of outbreaks caused by variants that are not susceptible to current vaccines? That was the conclusion from that meta-analysis. This is a very complicated slide, but basically what it means is that vitamin D helps to bring your system away from lung inflammation, from thrombosis, which means like an increased risk of blood clots. It reduces what's called an oxidative stress kind of situation in your body, over to tissue protection. So it brings your body away from tissue injury, which is causing most of the problems with serious COVID-19, severe COVID-19, to a tissue protective mechanism by what's called changing the balance between ACE, which is an enzyme that is sort of causes more tissue injury if it's left unchecked, versus the ACE2 stimulation of what's called angiotensin 1-7. So basically, it's moving the body from tissue injury to tissue protection, which is anti-inflammatory. It has antioxidant and anti-thrombotic kind of state. So it really helps in that way to have a vitamin D level that's high, if and when you get infected. And even from this study, which is a large study that was done by, in part by Quest Labs, actually, a lot of people were in this study. hundreds of thousands of people. And it showed that for every 1 point increase in vitamin D, there was an associated decreased risk of seasonal infection by 1.6% with every 1 nanogram per ml increase in vitamin D. And you can kind of see here that the sweet spot's around 50 to 55 nanograms per ml. So, and this association, it's an association, not causation, but it persisted across latitudes, like where you are in the world, geography wise, races and ethnicities, and genders. So this is like across the board, there was an associated decreased risk of infection, a big association between a serum vitamin D level that's higher and the rate of positivity of SARS-CoV was lower in those situations. So I think in summary there, we're probably looking at getting the vitamin D ideally above 50, for most people. And it's a little individual for each person, but that's kind of the target based on that data. Okay, so interleukin 6. This is talking about inflammation. We went over this on the most recent, the last time we did a webinar on Delta. We talked about this, but I'll just kind of go through this part quickly and just say that interleukin 6 is a chemical messenger that in some ways is good because it's involved in the early viral response phase in helping us fight off infection. And if someone has a lot of IL-6 and you're able to kind of stimulate those B cells and T cells to kill off the virus in the mouth or nose, they might even be asymptomatic or they might be non-severe symptomatic, which you see in that stage 1, stage 2 COVID-19 infection. But if IL-6 is basically persistently high, then you get a hyperinflammatory phase, what's called the cytokine storm, that accounts for most of the problems with COVID-19. So basically, some IL-6 is good, but too much is bad. So if we're in a point of time where we're too inflamed and there's too much IL-6 and you're starting to have sort of long symptoms like people are saying, these are some ways to reduce IL-6. Naturally, healthy nutrition, some fruits and veggies that you can kind of see on here, some supplements that could be helpful. This is all based on research here. Medications, not to go ahead and just take all these randomly, but just some of the things to think about. Limiting coffee. I know for all the coffee lovers out there, 1 cup a day in some studies have been shown to be helpful here. Quitting smoking and quitting drinking, reducing high glycemic index foods, so starchy carbohydrates like French fries, toast, etc., like that. Addressing stress, right? If you address stress, then you're less likely to want to eat those kind of high starchy foods, if you address stress. So address stress, address depression, address anxiety, address sleep quality to balance that interleukin 6. Now, let's talk about some practical things. Considerations if you're feeling sick. So see your healthcare provider, talk to them, do telehealth, and everything if needed. If you have red flag symptoms, these are things like shortness of breath and chest pain and all these type of things, go to, you may need to call 911 and go to the nearest emergency room, if it gets severe. And Omicron can still be severe too. So that is still possible. Medical treatments to think about, aspirin may reduce microclots and overall mortality in high-risk groups. There's some mixed data on this, but it depends on your risk level, I think. IV fluids can increase circulation of immune cells to vital organs. So that's very important, very helpful. Inhaled steroids can also help to reduce inflammation. And then a new study came out recently from, I think this was this week in The Lancet, showed that fluvoxamine, which is a selective serotonin reuptake inhibitor, did bind to sigma-1 receptors on immune cells, which essentially has the effect of reducing inflammation. And in this study, it reduced the need for hospitalization in outpatients that were at high risk for development of severe progressive COVID. Monoclonal antibodies within 10 days of symptoms. And then Paxlovid is not readily available yet. The FDA has given it an emergency use authorization. It is a viral protease inhibitor that I believe is made by Pfizer, I believe, but correct me if I'm wrong on that, Jen, but Paxlovid. So it's a viral protease inhibitor that inhibits viral replication. So that's probably happening down the line, and we'll have more information on it as stuff comes out. Natural protocols. So disclaimer, not FDA approved for prevention or treatment. Rinsing with mouthwash. So Listerine and other sort of more chemical mouthwashes have been shown to kill off coronavirus, including SARS-CoV-2 within 60 seconds. So that is one thing that you could do on a preventative or just a basis if you have a sore throat and things like that. Herbal mouthwashes like Tylenol and things like that are not as effective, but they do have some effect on reducing viral load in the studies. So there is that. I also think about increasing sodium chloride intake, so that's salt intake via electrolytes. You want to caution, if you're having leg swelling, i.e. edema, then you may not want to do this. But if you're taking in more salt in general and having some chloride, that's going to do a couple of things. One thing that's going to do, it's going to increase hypochlorous acid. So there's hydrochloric acid, which is HCl, which is stomach acid. So chloride does help produce stomach acid, which also helps kill off microbes. But it also, chloride also can turn into or get turned into hypochlorous acid, which is HOCl, which can kill off viruses. So that's another piece of the puzzle there. Bone broth, electrolyte powders, stuff like that. High dose vitamin D3, we can talk about questions if you want to talk about like doses and stuff, but high dose vitamin D3, not D2 as much in this case because of the binding to the D receptor is stronger with D3, but D3, vitamin C, zinc, quercetin. Quercetin is also antiviral because it binds to the spike protein, among other things. N-acetylcysteine, melatonin, glutathione, and then different herbals here, oregano. Someone just told me about Sinu Orega, which is very widely available at Walmart and all these places. It's a sinus rinse that has some herbals, including oregano in it. So that's pretty good. Seems like that's helped some people. Other times you can get oregano tinctures or tablets. There's different aspects of mechanisms for how these things help, but andrographis, turmeric, green tea, beta glucans, and mushrooms. CBD tincture is antiviral. So these last four I listed here, cannabidol from hemp extract, Chinese skullcap, astragalus, and licorice. All those four also inhibit the spike protein, just FYI. Licorice, you want to use caution if there's high blood pressure because the active ingredient called glyceric acid can raise blood pressure in theory. So there's FYI. Okay. Should I do questions or Jen, what do you think? Oh, it's already 1 o'clock. Maybe continue with this and then try to get to the questions. So long COVID, so the WHO, World Health Organization, did come up with a definition for this because a lot of people are getting long COVID now. At least 100 million people have a post-COVID-19 condition where, at least 3 months from the onset of COVID-19 with symptoms that last for at least 2 months, and that cannot be explained by an alternative diagnosis. Common symptoms of this long COVID include fatigue, shortness of breath, brain fog, cognitive dysfunction. Also, some people have loss of taste and smell for a long time, things like that. Tinnitus could be something there. Symptoms may be a new onset, or they may persist from the initial illness, and they may fluctuate or relapse over time. So kind of thought about this a little bit, and I think the IFM and many others are trying to come up with protocols and try to understand, why people are getting long COVID, why people are getting vaccine reactions. Here are some of the root causes that I kind of thought about, listed out here for you. Number one is an uncontrolled ongoing inflammation. So IL-6, again, it's going to trigger your immune system to get activated. But if it keeps on triggering triggering that inflammation cascade, that might cause immune attack on your own system, which can lead to either vaccine reactions or long COVID-19. Mitochondrial dysfunction. So what happens is ACE2, which actually keeps your system less inflamed over the long haul, when the cell and the ACE2 receptor in the cell gets hijacked by the virus, then the ACE2 functionality goes down. So it's what's called a battery drain. So the ACE2, one of the big things ACE2 does is it helps us make energy. So ACE2, if the ACE2 enzyme is not as functional, there's going to be more blood clots, more inflammation. But then from a perspective of fatigue, a lot of people have like chronic fatigue with long COVID. It's going to drain the batteries essentially. So inflammation's out of control. ACE2 goes down, ATP production goes down, the batteries get drained, and you feel fatigued. That's probably what's happening. That's what a lot of the experts are saying now in terms of what's causing long COVID is mitochondrial dysfunction from ACE2 functionality going down. Microclots are another thing. So basically microclots meaning that there's actually clots that are sort of in the system that may not be detectable by conventional imaging, but this may result in decreased circulation to critical organs, which might be causing some of these symptoms. Autoantibodies. So some of it could be an autoimmune condition. There's actually evidence that there's some antibodies. I think one is called annexin A1 that basically that help to control some of the cellular functions throughout the entire body. So antibodies that are produced by our immune system in response to this trigger of let's say COVID-19, you people might get long COVID from an autoimmune attack essentially. And then another aspect, recent studies actually showed that for some people, just like with like Epstein-Barr or Lyme or something like that, there is persistent infection in some people. And that's going to occur in various organ reservoirs, things like the brain and the gut and the heart and the kidney and things like that. I think gut is a big area, but there's different areas, different tissues that the virus can kind of hide out in, and we see that in a lot of other chronic infections. So that's another piece of the puzzle that I think we're all still trying to sort out here. Here's some general therapeutic thoughts. So sleep and rest, alternating rhythm breaks, meaning taking breaks throughout the day as needed, movement, healthy nutrition to support the energy, to bring that back up, mitochondria. Generally speaking, more healthy proteins and fats and not as many refined carbohydrates, biofeedback and neurofeedback, acupuncture and body work, reducing inflammation via phytonutrients, food sources of zinc and selenium. But then you also want to think about the veggies, the fruits, the spices, herbs, and teas. And you also want to consider intermittent fasting to stimulate the breakdown of damaged mitochondria, so so what's called mitophagy, so that your cells can produce more healthy mitochondria to get that ATP energy production back on track. Fermented foods, the reason for fermented foods, unless you have some histamine issues, but fermented foods in general are helpful to stimulate the growth of a healthy microbiome, healthy good bacteria, and that can also help to reduce inflammation. Other things that can help to promote and rebuild that ACE2 activity include vitamin D3 again, and resveratrol. Melatonin to reestablish circadian rhythms, and then general mitochondrial support. And we have some people on this here in our clinic, glutathione, NAD, CoQ10, and IV nutrients that our IV nurses can do to kind of support your mitochondria, get those batteries back up and running. If someone having brain issues, brain or nervous system issues, we can consider phosphatidylcholine. And then in general, for chronic fatigue, chronic inflammation, you think about low-dose naltrexone to reduce white blood cell inflammation and to reduce supportive brain cell, meaning glial cell inflammation as well. So here's some of the things to think about for long COVID, and I'm sure more research will come up and we can update you on that too. These are some general slides about immunocompetence, how to increase the chance that you will not have as much of a problem with COVID or any other virus. Is you want to regulate your blood sugar, get the blood sugar down, reduce and treat metabolic syndrome, because that's going to help your immune system be stronger. You want to increase T regulatory cells with vitamin A, D, and short chain fatty acids, increase natural killer cell activity, and activate your thymus gland, which is around right here on your body, to help to pump out more healthy T cells. That can really help. You can see what kind of helps there. Increasing some of the antibody levels, looking at the gut microbiome, maybe considering colostrum. And then balancing and optimizing hormone levels can actually help. There's actually associations, there's actually studies that show associations of healthy levels of different hormones all across the spectrum, adrenal, thyroid, and sex hormones associated with better outcomes in COVID-19 patients. Here's some other things here. These we talked about last time, so I'm going to just kind of run through this here. Lifestyle is important moving forward. Like I said, we'll keep reviewing the evolving guidelines. We'll, I'm sure, have another update at some point this year based on the guidelines for Omicron and potentially future variants. And here's some website links for the Institute for Functional Medicine. So, and just to put this into context in COVID and everything, so, what is the viral evolution? What does the future hold for variants? We're going to be moving towards an endemic time when we're going to have to live with this virus. So how do we learn how to live with this virus? How do we balance health? How do we promote physical safety, psychological safety, global immunity, basically fortification of our collective immune terrain? How can we reopen society with all these things in mind and restore our spirit? In due time. So how do we promote connection? And thank you for this question too. How do we promote connection? And we may have to get creative about this while we are going through this. So the lessons that I think we've all learned is that we are all connected to each other in ways we might not have even imagined in 2019. But now here we are, in 2022, at least about 2 years later now and beyond, and we're all in this together. So wanted to just thank you for staying on. I know it's past an hour. Let's just do this one breathing practice if you're still on here, and just put your hand in your heart. And now we kind of strengthen our immune system and said some gratitude to our immune system at the beginning of this conversation and discussion here. Let's do some more breaths, but this time connect to all of us on Zoom and community that are out there watching this, whether they're watching this live now or afterwards, but sending energy to each other around the country, across the world, supporting our collective global terrain, just sending some positive energy to each other right now. Breathing in and out together, uniting together, sending well wishes to each other for those who are previously been affected, currently affected by COVID, or your loved ones, just sending them some healing wishes for a speedy recovery. So one more breath in and out at your own pace. Okay, I know that this will be recorded, so thank you for listening. And if there's any other questions, just type them in the chat. I'll try my best to get to them. Do have some extra time that we kind of budgeted here too. So I think I'm back to, yeah, Jennifer was saying cloth masks with a PM 2.5 filter. Yeah, are there some out there? Just put that in the chat. That would be great. That would be great if we could, if you know of that, we can look at that for sure. I mean, vaccine side effects and risks, that there are definitely some people that we've seen with tinnitus or myocarditis or fatigue, or, different things like that. I mean, there are some potentials for side effects and risks. I think you can get that with the vaccine or with infection. I think you know, wondering how do you have it go away, basically, right? That's a really good question. I mean, we're still trying to figure that out. I think we're all trying to figure that out. I think just going back to what I said before for some of the other questions, just reducing inflammation overall, supporting the nervous system, building up the mitochondria. We think in functional medicine about tinnitus and ear ringing being a mitochondrial issue. There's not enough battery power to those areas, to those nerves that are supplying the ears and the hearing, so that if you support the mitochondria, support the myelin sheath, all of that stuff, decrease inflammation. Those are the type of things we think about in terms of how to decrease that. Think about acupuncture, obviously decrease your autonomic nervous system reactivity, do heart math, do some meditation, all these type of things to balance out. So that's what we think about, and then get the vitamin D level up, right? We know that, again, infections and vaccinations will at least transiently increase interleukin 6. So you want to do some things to decrease IL-6, including getting your vitamin D levels up. Put a link in there, Bo. Thank you. Synovia masks. That's a good one. Can you just put a link in there? Thank you. Jen, could you take down all these comments? These are great. Luminora is another one. Thank you. Just take down those comments, Jen, if you could. Thank you. This is great. Thank you. Vaccines will, okay. So, right, effectiveness of vaccines, there's different metrics being measured. So most of the studies are saying that vaccines are not that effective now against symptomatic infection, so there's effectiveness against symptomatic infection. There's effectiveness against preventing hospitalization and death. So vaccines are considered not as effective now with Omicron. The variants could always change over time, but kind of like the flu vaccine, right? We have annual flu vaccines. Some years they're more effective than others, right? But in theory, flu vaccine would also decrease the risk of hospitalization and death from the flu. I mean, that's the idea, even if they're not always 100% effective in preventing symptomatic disease. But I hope that makes sense. So there's exposure, infection, and then severe outcomes. They're different metrics. Vaccines for someone with mold toxicity or heavy metal toxicity, that's a good one. I mean, in general, I would say that you want to try to clean up your system and before getting a vaccine, ideally. I mean, it sort of depends on the situation there. So if someone's having an active symptom from, like, let's say some people have tinnitus, right, from mold toxicity or something like that, then that ideally you clean that up, you clean up the gut, you clean up the detox system, get some of the toxins out of there. That would be better to do before getting the vaccine, but it depends on the situation. That's what we found clinically anyway. I mean, that's not necessarily an official recommendation, but that's the idea, is you want to kind of clean up your innate terrain first before getting a vaccine, ideally. If it's something where it's like, is it impossible to clean up that terrain in a good amount of time? There's some things to do that can mitigate. If you do get a vaccine, there's things that can mitigate inflammation. We think about vitamin D again, glutathione. Sometimes we'll give IVs in the clinic before vaccines and things like that. So there's things you can do like that too. Grapefruit seed extract. I don't know if it's been studied specifically for coronavirus, but it does have antiviral effect. So yeah, I mean that makes sense to do some. Like, I know some people have done neti pot with some grapefruit seed extract drops in there. Once your family members recover from Omicron, once they test negative, yeah, after 5 days, sure, that would be fine. It seems that would be fine by the guidelines. Yep. Thank you, Eleni, for that monoclonal link there. Yes, we are giving referrals for monoclonal antibodies. The problem is that sometimes the treatments are not that available right now. There is one place in Tacoma Park that's part of the Adventist system that we've been sending people. If you were infected on or around the same day you received your booster, would the infection weaken the effectiveness of the booster? I don't think so, but there might be some, you know, sort of overlapping input. It's hard to say. That's a hard one. But yeah, I think that's a good question. It's a good question. Yeah, another good question. There's some concern that all these vaccines may eventually start to reduce your immune support. And that's the concern they're considering before announcing a need for the fourth. A lot of the public health experts are saying that, actually, is I think it's not clear whether or not we'll need like annual boosters or twice a year booster or something like that. I think that there is some thought about that. I think I need to dive into the research more on that to have more of an opinion on that, but that's definitely a thought out there about how repeated vaccines affect your immune support. And it probably depends on each person too, and like risk benefit and things. So I think there's just not enough data about that right now. I'm curious to see what comes out about that. Would a cloth mask with a PM 2.5 filter inside be effective? I don't think there's studies on that. If you find a study, let me know. I mean, in theory, it would be more effective than just a cloth mask. Cloth mask, yeah. Ways to support the nerves, yeah. Phosphatidylcholine, lion's mane, glutathione, IVs. That would be ways to support the nerves. What if you're not sure if you had Omicron, you had a bad cold? Should you still wait 90 days before a booster? That's a hard question. If you think other people around you had Omicron and you got similar symptoms, I mean, we have a lot of people, like the family members had Omicron, but then they couldn't get a test, but they have similar symptoms. I would assume that you had Omicron, yeah. Yeah, I saw that, Linda, the new EU warning that says constant boosters could adversely affect immune response. I did read that article as well. I need to look more into the data on that, but I think that's what the other person was saying as well, that's a concern. So something we're going to look into for sure. Oh, I didn't know that. So zoo animals and dogs are dying from COVID as well. I'm not sure. Any vets out there? I'm not sure. I mean, we do want to protect our dogs and animals and stuff, right? Probably don't want to be coughing in their face. Yeah. Yeah, 50 to 80. Yeah, 50 to 80 is good. Is a good range. Yeah, that's a good range for D. Povidone iodine is mouthwash. That is considered effective based on the studies. It's antiviral. I think how easy is it to get? I'm not sure, but that is considered effective based on the studies. Yeah. Natural protocols for teens. I mean, these are all short-lived protocols, antiviral protocols. So I would say probably not, but we can look at specific things, I guess. Doses, it depends on the person, but vitamin D, we're probably looking at, if you have COVID and if you're doing like prevention, then probably like 5 to 10,000 units of D, 2,000 of C, sort of depends on the situation. For treatment, you're probably looking at higher doses often, like 10, 25, or even higher, 1,000 for a week, let's say, of D, and then maybe even up to 10 or 20 grams or more of C to bowel tolerance, which means it can cause a loose stool. For zinc, probably 15 to 30 milligrams, and then quercetin. And it depends on the person. So again, just kind of take that with a grain of salt here. I would definitely say there, probably 500 twice a day would be a good starting dose. Yeah, thoughts on how to treat potential of microplaques. I think aspirin, curcumin, nattokinase, lumbar kinase. The vaccines and change in menstrual cycles. Anyone want to take that one? I think the thought, I think the conclusion of that, because I did read about that one. I think it was saying that it was temporary, like it didn't last that long. But if people have more information about that, natural mint mouthwash, I don't think that's been studied. It probably has some effect, but not a huge effect. Yeah, yeah. Lumbar kinase enzymes can reduce clots in theory. I don't know if it'll work for this per se, but in theory, that's what it does, and we have seen that work for other conditions. So thank you so much. Thank you, Mustafa. Yeah, thank you, everyone. And thank you so much for all of this, and yeah, sending love and gratitude. Hey, Linnea, good to see you. Thank you so much. Love to all of you. Um, Great, great. I'm glad that this is helpful for people. Thank you, Kathleen. The links are here. Novavax, yeah, that's a good one. I have to read more about that, because we don't have it here. I haven't been researching it as much. I think maybe I can ask our team to look into and research that and the side effects of Novavax versus other ones. I'm not sure if it's coming to the US or not. We can we can double check. I don't know that there's any obvious plans for that, but that's a good point about that versus other ones. How important do you think it is for a booster for a healthy young adult, given that they don't protect from Omicron very well? Yeah, that's a good question. For a booster, well, a booster would protect against severe illness. They don't really protect that well against symptomatic infection. So it depends on, I think, the risk and benefit ratio for that person, and it's something probably we could talk about um, more that way. Yeah, we do have binding and detox protocols. Yep. Fluvoxamine, we haven't done too much of that yet. I mean, it's fairly new. I think it would be reasonable to try it out based on the data, though. I think that would be reasonable. Yeah. Thank you, everyone. Good to see everyone. Hope everyone's staying safe and healthy. And we'll talk to you later. Thank you so much. Have a good weekend, everyone.